Welcome to the Endocrine and Hematologic Emergencies module. The endocrine system influences almost every cell, organ, and function of the body. Consequently, patients with an endocrine disorder often are seen with a multitude of signs and symptoms that require a thorough assessment and immediate treatment. This module discusses both endocrine and hematologic emergencies, which rarely occur in most EMS systems. Although hematologic disorders can be difficult to assess and treat in a pre-hospital setting, your actions may not only offer support, but you may save the patient's life. Click on the link to view the chapter objectives. The major components of the endocrine system include the hypothalamus, the pineal gland, pituitary gland, thyroid gland, thymus gland, parathyroid gland, and adrenal glands, the pancreas and the gonads, including the ovaries and testes. The endocrine system comprises a network of glands that produce and secrete chemical messengers called hormones. Hormones travel in the bloodstream to target tissues. Hormones are involved in regulation of mood, growth and development, metabolism, tissue function, and sexual development and function. Endocrine glands secrete or release chemicals such as hormones inside the body. The main function of the endocrine system and its hormone messengers is to maintain homeostasis and promote permanent structural changes. Maintaining homeostasis requires a response to any change in the body, such as low glucose or calcium levels in the blood. Click on each hotspot for more information on the endocrine system. Glucose, or dextrose, is one of the basic sugars in the body, and along with oxygen is the primary fuel for cellular metabolism. Some cells will not function at all without glucose. Without glucose, or with an extremely low glucose level, brain cells rapidly suffer permanent damage. A normal blood glucose level in non-fasting adults and children is approximately 70 to 120 milligrams per deciliter. Insulin is a hormone produced by the pancreas that facilitates the uptake of glucose from the bloodstream into the cell. With the exception of the brain, insulin is needed to allow glucose to enter individual body cells to fuel their functioning. For this reason, insulin is said to be a cellular key. Regulation of glucose levels in the body is a complex and dynamic process that begins when absorbed carbohydrates stimulate the release of insulin from the beta cells of the islets of Langerhans in the pancreas. Insulin is responsible for the removal of glucose from the blood for storage as glycogen, fats, and protein. Click to expand each tab for more information on the effects of glucose levels. Endocrine disorders can be caused by either hypersecretion or insufficient secretion of a gland. Hypersecretion presents as overactivity of the target organ regulated by the gland. Insufficient secretion results in underactivity of the organ controlled by the gland. Hyperthyroidism and hypothyroidism are two serious illnesses of the endocrine system. However, most of the endocrine emergencies you will encounter will be related to diabetic emergencies secondary to abnormal insulin secretion. Hyperthyroidism increases metabolism, while hypothyroidism decreases metabolism. The table summarizes the major effects of hypothyroidism and hyperthyroidism. Although approximately 20 million Americans have some type of thyroid disorder, many are unaware of their condition. Treatment of these patients should be symptomatic with transport to the closest, most appropriate facility. Diabetes is a metabolic disorder that is now thought to be associated with a group of complex diseases with many causes. These pathologic conditions reflect a flaw in the production or function of insulin or both. Insulin assists in the metabolism of carbohydrates and the transport of glucose into the cells. The end result of diabetes is hyperglycemia, also known as high blood glucose. Medically, the term diabetes refers to a metabolic disorder in which the body's ability to metabolize simple carbohydrates is impaired. It is characterized by polyphagia, polydipsia, and polyuria. In diabetes, excess glucose is excreted in the urine and attracts water, resulting in excessive diuresis. Diabetes mellitus is characterized by the body's inability to sufficiently metabolize glucose. In people with this disease, the pancreas does not produce enough insulin, or the body's cells do not respond to the effects of the insulin that is produced. In either case, the result is the same, an elevated level of glucose in both the blood and the urine. Glucose builds up in the blood, overflows into the urine, and flows out of the body. Because the lack of effective insulin prevents the sugar from moving inside the cells where it can be metabolized, cells can actually starve, even when the blood contains large amounts of glucose. Diabetes mellitus is responsible for myriad life-altering complications. Click to expand each tab for more information. Conditions that develop subsequent to the onset of diabetes respond more effectively when diabetes is managed appropriately. Conversely, any kind of distress can have a negative effect on the patient and result in blood glucose levels that are more difficult to control in the setting of increased physical activity or emotional stress. Both chronic and acute complications are associated with diabetes mellitus. Although these complications are present in both forms of the disease, they tend to be more severe in people with diabetes who require insulin. Left untreated, diabetes results in organ system dysfunction, wasting of body tissues, and death. Even with excellent medical care, some patients with particularly aggressive forms of diabetes will die at a relatively young age from complications of the disease. The severity of diabetic complications correlates with the average blood glucose level and the age of onset. Although some patients with well-controlled diabetes have a normal lifespan, they must be willing to adjust their lives to the demands of the disease, especially their eating habits and physical activity levels. There is no cure for the disease, so treatment focuses on maintaining the level of blood glucose within the patient's normal range. Two forms of diabetes mellitus exist, type 1 and type 2. The age of onset of the patient's symptoms is less important than whether the patient requires insulin to survive. Both types of diabetes mellitus are serious conditions, and both require lifelong medical management. In addition, the condition known as prediabetes is now recognized as a warning sign that may precede the development of type 2 diabetes. Type 1 diabetes has historically been referred to as insulin-dependent diabetes mellitus or juvenile onset diabetes because it generally affects children. Although type 1 diabetes has a hereditary predisposition, it is believed that environmental factors may play a role, for example with an infection that triggers an autoimmune disorder. With type 1 diabetes, the body develops autoantibodies that incorrectly identify the body's own tissues or substances as foreign invaders to be destroyed. Contributing to pancreatic destruction, are autoantibodies to the insulin-secreting beta cells in the islets of Langerhans, to insulin, and to other pancreatic substances. The rate of beta cell destruction is variable, occurring rapidly in some patients, mainly children, and slowly in others, mainly adults. Eventually, the pancreatic beta cells become incapable of secreting insulin and regulating intracellular glucose. Because beta cells are the only source of insulin, it must then be administered by injection or with a pump when the cells are destroyed. Latent autoimmune diabetes in adults is a variant of type 1 diabetes that occurs in adults older than 30 years. The pathophysiology is the same as that of young-onset diabetes, with the body's immune system destroying the beta cells, so adult patients with latent autoimmune diabetes will ultimately require insulin therapy. People with type 1 diabetes require daily injections of supplementary synthetic insulin throughout their lives to control blood glucose levels. In addition to daily insulin injections, strict dietary control must be observed, which can be difficult to achieve with young children. Increased activity and alcohol consumption can result in low blood glucose levels, so in adults with type 1 diabetes, alcohol consumption also must be controlled. In terms of management, type 1 diabetes always requires the use of insulin administered by injection or an insulin pump, also called continuous subcutaneous insulin infusion therapy. Insulin cannot be ingested orally because the digestive process will render it inactive. You will likely encounter patients with diabetes who use insulin pumps to treat their disease. An alternative to multiple daily injections of insulin, insulin pumps provide improved control of blood glucose levels and better quality of life for many patients. These small devices consist of an infusion set, a reservoir for insulin, and the pump itself. The pump is approximately the size of a deck of cards, weighs approximately 3 ounces, and can be worn on a belt or carried in a pocket. Insulin is administered through a catheter under the skin. The pump is often set to deliver a basal amount of insulin continuously throughout the day. Alternatively, the pump can be set to deliver a bolus of insulin at specific times, such as meal times when blood glucose levels are high. The most common form of diabetes is type 2 diabetes, in which blood glucose levels are elevated because the body becomes resistant to the insulin produced and cannot produce enough insulin to overcome that resistance effectively. Type 2 diabetes can also be caused by a deficiency in insulin production. Type 2 diabetes typically develops when a person is middle-aged, although the disease is becoming more common in younger people. In some cases, an abnormal increase in the production of glucose by the liver causes an increase in blood glucose levels. Normally, when blood glucose and insulin levels are low, the pancreas releases glucagon and stimulates the liver to produce and release glucose into the blood. In some people, however, the levels of glucagon stay high. When glucagon levels remain high, excess amounts of glucose are produced, resulting in high blood glucose levels. Symptoms of untreated type 2 diabetes may include those listed here. These symptoms tend to develop gradually and usually become noticeable in middle age. In fact, the onset of type 2 diabetes may be so insidious that patients may not realize they have it. In some instances, the symptoms can develop over several years in overweight adults older than 40 years. A small percentage of patients do not display any symptoms. Weight loss is an important factor in helping to control type 2 diabetes. Exercise and a well-balanced, nutritious diet are key components in combating the complications of diabetes. To maintain glucose levels within the normal range, food intake must be spread throughout the day in coordination with daily oral medications and/or insulin injections and monitoring of glucose levels with a glucometer. Metformin, the medication most commonly prescribed for the management of type 2 diabetes, causes a decrease in glucose production. Prediabetes is a condition identified in people who have certain risk factors associated with type 2 diabetes and exists when blood glucose levels or hemoglobin A1C levels are above normal levels, yet not high enough to be diagnosed as diabetes. The A1C blood test reveals information about the patient's blood glucose levels over the prior 3 months. Risk factors for experiencing this disease course include those listed here. Although some of the risk factors affecting the pathway from prediabetes to type 2 diabetes cannot be altered, others can. According to the CDC, interventions affecting 2 specific factors can help prevent or delay the onset of type 2 diabetes by 58%, specifically losing 5 to 7% of the patient's body weight and getting at least 150 minutes of physical activity per week. Gestational diabetes does not have a pancreatic component, but rather is a form of glucose intolerance that can occur during pregnancy. Women who experience gestational diabetes during pregnancy have a 40% to 60% increased risk of developing type 2 diabetes within a decade. For most women, gestational diabetes will resolve before delivery. In a few women, however, diabetes will not resolve, or type 2 diabetes will develop. Blood glucose crosses the placental barrier. When a pregnant woman is hyperglycemic, high levels of glucose enter the fetus, causing increased production of insulin by the fetus in an attempt to normalize blood glucose levels. The extra glucose is converted into fat in the fetus, such that women experiencing gestational diabetes often deliver large babies and may encounter difficult deliveries. Often, cesarean sections are required. Gestational diabetes is usually diagnosed at 28 weeks gestation and peaks in the 3rd trimester of pregnancy. It is thought that 2 hormones produced by the placenta, progesterone and estrogen, result in insulin resistance. Because this condition does not occur until later in pregnancy, it does not produce birth defects. Infants of mothers in whom gestational diabetes developed are at higher risk for obesity and diabetes in their lifetime. Initiate management of gestational diabetes as soon as possible to stabilize blood glucose levels and minimize potential complications to both mother and baby. Management includes diet modification, exercise, and blood glucose testing. Oral medications are not prescribed for this form of diabetes, and insulin injections may be required. Select the correct answer from the drop-down options for the question below and then click Submit. Hypoglycemia in a person with type 1 diabetes is often the result of having taken too much insulin, too little food, or both. The tissues of the central nervous system, unlike other tissues that can metabolize fat or protein in addition to sugar, depend entirely on glucose as their source of energy. If the level of glucose in the blood decreases dramatically, the brain is literally starved. Hypoglycemic crisis, also known as insulin shock, is the result of hypoglycemia or insufficient glucose in the blood. Counter-regulation is the body's natural defensive ability to maintain blood glucose at an appropriate level. The body's first line of defense against low blood glucose is to reduce insulin production by the pancreas and to increase glucagon production by the alpha cells. When cells are deprived of glucose, a distress signal goes out over the sympathetic nervous system, causing the release of various stress hormones. The body's second line of defense is the secretion of catecholamines, including epinephrine and norepinephrine, by the adrenal gland. The effects of this release can be seen as tachycardia and diaphoresis in the hypoglycemic patient. This second line of defense also includes cortisol, an adrenocorticoid. Cortisol release results in an increase in blood glucose levels, which counteracts insulin's actions. Other hormones produced by the intestine and growth hormone produced by the pituitary gland also increase blood glucose levels. Last, stimulation of the autonomic nervous system generates signals that allow production of counter-regulatory hormones to increase. The same stimulation also triggers symptoms telling the body that the blood glucose level is low. Ideally, the affected patient will recognize these symptoms and consume a source of sugar to remedy the imbalance. In response to the action of these hormones, the body mobilizes fatty acids and amino acids from adipose and muscle, respectively. The liver uses these products to make new glucose for the body in a process called gluconeogenesis. In patients with type 1 diabetes, the islets of Langerhans do not make insulin. As a result, the body's first line of defense against hypoglycemia is lost because the ability to decrease insulin levels no longer exists. Often, a low blood glucose level is caused by an elevated level of exogenous insulin from inaccurate dosing, intentional overdose, or perhaps a mismatch with carbohydrate intake and exogenous insulin intake. In addition, increased use of glucose, such as what occurs during exercise, causes the blood glucose level to drop sharply, resulting in hypoglycemia. In patients with type 2 diabetes, the pancreas can generate insulin, so these patients can suppress insulin production from within their own bodies. However, their bodies may be resistant to the effects of insulin, or they may not make enough insulin over time to lower the blood glucose level adequately. Medications for type 2 diabetes act by either stimulating the body's ability to secrete insulin or by improving insulin's actions. These medications tend to contribute to hypoglycemia, especially in certain groups of patients, such as older adults and those who are not metabolizing the medications properly because of liver or kidney disease. Some patients who have had type 1 diabetes for many years, and to a lesser degree patients who have had type 2 diabetes for many years, may not experience a glucagon release from the pancreas in response to hypoglycemia. Lack of glucagon response makes the body more dependent on epinephrine to overcome the effects of hypoglycemia. Yet there may be some lack of responsiveness to epinephrine in diabetes as well. Prolonged disease can also decrease a patient's ability to recognize having a low blood glucose level, preventing him or her from taking the necessary measures of self-treatment. The patient with hypoglycemia will experience trembling, a rapid heart rate, rapid, shallow respirations, sweating, and a feeling of hunger. The brain is highly sensitive to glucose levels, and so these symptoms reflect both the disordered function of hungry brain cells and the alarm reaction, sympathetic nervous system discharge, set off by the brain's distress signals. If hypoglycemia persists, cerebral dysfunction progresses quickly to permanent brain damage. Some of the most common signs and symptoms of hypoglycemia include those listed here. Hypoglycemia is a common problem experienced by patients with either type 1 or type 2 diabetes. It develops rapidly over a period ranging from minutes to a few hours and should be suspected in any patient with diabetes who presents with bizarre behavior, neurologic signs such as altered mental status, or weakness or facial drooping similar to a stroke or coma. Often a hypoglycemic patient appears intoxicated because of slurred speech and lack of coordination, and may be paranoid, hostile, and aggressive. Although it is not completely preventable, hypoglycemia can be treated easily. This condition can be detected with regular blood glucose monitoring and rarely results in complications for the patient if identified and treated promptly. In contrast, severe hypoglycemia resulting in loss of consciousness or altered mental status is a more common reason for a call to 911 and requires intervention and treatment. If untreated or not detected, serious hypoglycemia can result in coma or death. Of course, people with diabetes are not the only ones likely to have episodes of hypoglycemia. Patients with alcoholism, patients who have ingested certain poisons or overdosed with certain drugs, and patients with certain cancers, liver disease, kidney disease, and some other conditions may also experience hypoglycemic episodes. Do not discount the possibility of hypoglycemia in a comatose patient just because the patient is not known to have diabetes. Conversely, do not let a known diagnosis of diabetes prevent you from considering other causes of coma. People with diabetes can also experience head injury, stroke, seizures, meningitis, and other traumatic injuries or conditions. The presentation of these conditions may appear similar to diabetic emergencies. Keep an open mind and assess the patient thoroughly. Without insulin, glucose from food remains in the blood and gradually rises to extremely high levels. Normally, high carbohydrate levels are tolerated and return to normal by means of metabolic pathways. Problems arise when the blood glucose level remains elevated and the mechanisms that normally correct this have failed. This condition is called hyperglycemia. When serum glucose levels rise above tolerable levels, physiologic changes occur that represent actual pathologic conditions called diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome. DKA is associated predominantly with people with type 1 diabetes. A life-threatening condition, DKA occurs when certain acids accumulate in the body because insulin is not available. Common causes of DKA include infection, injury, alcohol use, emotional distress, and illness such as stroke or myocardial infarction. In patients with DKA, hyperglycemia continues. That is, glucose continues to accumulate in the blood. Eventually, the patient undergoes massive osmotic diuresis. The process of excreting so much glucose in the urine requires a large amount of water. The loss of water in such large amounts causes the classic symptoms of uncontrolled diabetes, the 3 Ps, polyuria. Without glucose to supply energy for cells, the body must turn to other fuel sources, the most abundant of which is fat. Unfortunately, when fat is used as an immediate energy source, chemicals called ketones and fatty acids are formed as waste products and the signs and symptoms of hypoglycemia and hyperglycemia can be similar. The signs and symptoms of simple hyperglycemia are usually mild, if present at all. If you encounter a patient with simple hyperglycemia who has not progressed to a more serious syndrome, treatments should include supportive care and transport. Hyperglycemia usually HHS is also called hyperosmolar non-ketotic coma, or HONC, a metabolic derangement that occurs principally in patients with type 2 diabetes. This condition is characterized by hyperglycemia, hyperosmolarity, and an absence of substantial ketosis. The term hyperosmolarity describes highly concentrated blood as a result of relative dehydration. Key signs and symptoms of HHS or HONC include those listed here. Less than 20% of patients present in a comatose state. Instead, most patients have severe dehydration and focal or global neurologic deficits. In addition, AMI is frequently associated with HHS or HONC. The clinical features of HHS or HONC and DKA tend to overlap and are often observed simultaneously. HHS or HONC often develops in patients with diabetes who have a secondary illness that results in reduced fluid intake. Although infection is the most common cause, many other conditions can cause altered mentation or dehydration. In most cases, the secondary illness is not identified. Unlike patients with DKA, patients with HHS or HONC do not experience ketoacidosis. The onset of DKA can occur in as little as a few hours, whereas HHS or HONC can take up to weeks to develop. Blood glucose levels tend to be substantially higher in HHS or HONC as compared with DKA. The stress response to any acute illness tends to increase hormones that favor elevated glucose levels. Various neurologic changes may be noted, including drowsiness. Select the correct answer from the drop-down options for the question below and then click Submit. Assessment of a patient with a history of diabetes is similar to your assessment of any other medical patient. In addition to hyperglycemic and hypoglycemic crises, patients with diabetes may have silent or painless heart attacks. A patient's only symptom may be not feeling so well. This is especially true of geriatric patients. It is imperative to maintain a high index of suspicion and treat patients aggressively. Evaluate scene safety as you arrive and as you approach the patient. Make sure that all hazards are addressed. Remember that diabetic patients often use syringes to administer insulin, and it is possible you may be stuck by a used needle that was not disposed of properly. Insulin syringes on the bedstand, insulin bottles in the refrigerator, a plate of food, or a glass of orange juice are important clues that may help you decide what is possibly wrong with your patient. Evaluate each situation quickly and make sure the necessary personal protective equipment is readily available. Standard precautions should consist of gloves and eye protection at a minimum. As you approach, question bystanders on events leading up to your arrival. Determine whether this is your only patient and whether trauma was involved. Decide whether you will need any additional resources. Do not let your guard down, even on what appears to be a routine call. Perform a rapid scan of the patient to form a general impression. How does the patient look? Does he or she appear anxious, restless, or listless? Is the patient apathetic or irritable? Is the patient interacting with his or her environment appropriately? In patients with altered mental status, suspect a low blood glucose level. Identify life threats and provide life-saving interventions, particularly airway management. Determine the patient's level of consciousness using the AVPU scale. An unresponsive patient may have undiagnosed diabetes. Perform cervical spine immobilization when indicated and provide rapid transport. At the emergency department, diabetes and its complications can be quickly diagnosed. Patients showing signs of inadequate breathing and altered mental status. Investigate the chief complaint or the history of the present illness. Responsive patients can usually provide their own medical history. If the patient has eaten but has not taken insulin, it is more likely that hyperglycemia is developing. If the patient has taken insulin but has not eaten, the problem is more likely to be hypoglycemia. If time allows, conduct a secondary assessment. Assess unresponsive patients. It is important to reassess the diabetic patient frequently to assess changes. Click to expand each tab for more information on emergency management of endocrine emergencies. Review your knowledge of the material by answering the following question. Click on the correct answer option and then click Submit. Oral glucose is commercially available in tablet and gel forms that dissolve when placed in the mouth. Trade names for the gel include glucose and instaglucose. The only contraindications to glucose are an inability to swallow or unresponsiveness because aspiration can occur. Oral glucose itself has no side effects if it is administered properly. However, aspiration in a patient who does not have a gag reflex can have lethal results. If your hypoglycemic patient is unresponsive, or if there is any risk of aspiration, do not give anything. If the hypoglycemic patient has an altered mental status or is unable to swallow, you will need to administer IV dextrose. Exercise caution when using dextrose. Contraindications include the presence of increased intracranial pressure or possible intracranial bleeding. When the unresponsive patient is older than 55 years or the family gives a history of recent transient ischemic attacks or stroke, assess glucose levels to rule out hypoglycemia prior to administering IV dextrose. Also, use caution with patients suspected of having hypokalemia, such as patients who are taking diuretics. Administering glucose in the presence of hypokalemia worsens the effects of low potassium. However, the potential for worsening the patient's hypokalemia should not be a factor when dealing with a severely hypoglycemic patient. Dextrose comes packaged in various concentrations. The total dose of dextrose in these formats is the same, though the concentration and volumes differ. Dextrose may cause serious damage to tissue from extravasation outside the vein. Therefore, you must give dextrose by IV push while carefully monitoring for infiltration into local tissue. The steps for administering dextrose to a patient with an altered level of consciousness are summarized here. Administering glucagon IM is an option when you cannot obtain IV access in a hypoglycemic patient. However, it is important to remember that glucagon is only effective when there are stores of glycogen to draw from. If glycogen stores are depleted, glucagon will be ineffective. Click to expand each tab for more information on the management of hyperglycemia, DKA, and HHS or HONG. Review your knowledge of the material by answering the following questions. Select whether each statement listed is true or false, and then click Submit. Hematology is, by definition, simply the study of blood. However, the specialty addresses not only the blood, but also the ways in which its constituent parts are involved in health and disease. These components include red blood cells, or RBCs, white blood cells, or WBCs, platelets, and individual proteins involved in the bleeding and clotting cascades, as well as the hematopoietic system. Most EMS systems rarely respond to hematologic emergencies. The blanket term hematologic disorder refers to any disorder of the blood. Within this general category, hemolytic disorders refer to disease processes that cause the breakdown of RBCs, and hemostatic disorders refer to bleeding and clotting abnormalities. These disorders can be complex, difficult to assess, and challenging to treat in the pre-hospital setting. As an AEMT, you should have a basic understanding of the hematopoietic system and hematologic disorders, and know how to respond to these kinds of emergencies appropriately. Although you may be able to provide only limited interventions in the field, your actions may not just offer support, but actually save the patient's life. Without blood, we would not be able to live. Blood performs the functions listed here. Click to expand each tab for more. Hemostasis is a highly complex process that allows the body to stop bleeding through vascular spasm, coagulation, and platelet plugging. The opposite of hemostasis is hemorrhage. Clots themselves are made up of fibrin. When injury is detected, thrombin converts fibrinogen to fibrin, and the clotting process begins. Calcium acts as a binding agent, holding fibrin fibers close together to form the meshwork of the clot. Any process that interferes with the activation or continuation of the clotting cascade, or hemostasis, is known as a coagulopathy. Coagulopathies can result in heavy or prolonged bleeding. One such bleeding disorder is von Willebrand disease, in which the blood's ability to clot is decreased because of the absence of a key protein. Although many parts and organs of the human body can alter or affect the hematologic system, the major players are the bone marrow. To ensure compatibility and prevent medical problems during blood component replacement, blood type classifications have been developed. The ABO system uses the RBC. Sickle cell disease is the most common inherited blood disorder. Although it primarily affects African American, Puerto Rican, and European populations, it can occur in anyone. A sickle cell crisis may manifest in several ways. As a vaso-occlusive crisis, anemia is defined as a hemoglobin or RBC level that is lower than normal. Your basic assessment should be the same for all patients, although you may want to ask some specific questions when you suspect anemia. A clotting disorder is a condition in which there is an abnormality in the blood's clotting ability. The development of a blood clot is called thrombosis and can occur in either arterial or venous. Assessment of a patient suspected of having a hematologic disorder should be no different from assessment of emergency medical care for any patient with problems related to a blood disorder should include the interventions. Review your knowledge of the material by answering the following question. Click on the correct answer or answers and then click Submit. Click to expand each tab for more information on the management of specific hematologic conditions. In this module, we began with a review of the anatomy and physiology of the endocrine system and described the various types of diabetes and how their onset and review your knowledge of the material by answering the following questions. Click on the correct answer option and then click Submit. Congratulations! You have completed the Endocrine and Hematologic Emergencies module. You may now close the module.